Assalamu alaikum. This is a presentation on conditions that can cause bilateral parotid gland swellings. We shall briefly go through infective processes, whether viral or bacterial, recurrent conditions in children and in adults, Sjögren syndrome, granulomatosis with polyangiitis or sarcoidosis, sialadenosis or polycystic parotid disease, and induced conditions like Mumps, Anaesthesia mumps, iodide mumps, and radioactive iodine sialadenitis, and Neoplastic conditions including Warthin's tumour and MALT lymphoma. Mumps, which is also called epidemic parotitis, is of course the most common viral inflammation of the salivary glands. It's caused by a paramyxovirus, an RNA virus that is related to influenza and parainfluenza viruses. It's mostly a disease of childhood. In 85% of the cases, the affected patients would be less than 15 years of age. The peak incidence age would be somewhere between 4 and 6 years. 95% of the adults have antibodies against mumps, either through vaccination, mostly, or previous exposure. The disease is transmitted via droplet route from salivary or nasal secretions or from the urine. The incubation period is fairly long, between 14 and 18 days, and the patients will be infectious about 3 days before the onset of the salivary gland swelling to about 7 days after the appearance of the swelling. It starts with a prodromal period between 1 and 3 days, with fever, chills, malaise, loss of appetite, sore throat, and facial pain. And then parotid swellings would be noticed, usually bilaterally, but it can start initially on one side and followed by the other a little bit later. It's usually the parotids that are involved, but submandibulars can be infected as well, and rarely sublingual glands as well. In the parotids, there will be local pain and edema, and the patient may describe otalgia and minimal trismus. The swelling usually lasts between 2 days and 1 week. The Stensen's duct papilla will be congested and swollen, but no pus could be expressed through the papilla. Sometimes the submandibular gland and neck nodes would also add to the clinical picture. Rarely the sublingual gland could be swollen, and if this happens, the floor of the mouth and the tongue will be elevated and cause dysphagia and dysarthria. The treatment is basically preventable. Vaccination against measles, mumps, and rubella, the MMR vaccine, is extremely effective. There is no specific treatment as such for mumps, and it's treated primarily with supportive care, with analgesia and appropriate fluid intake. However, corticosteroids can be effective if the condition is severe. It's usually not required unless the patient has other systemic symptoms, like, for example, orchitis or pancreatitis. The main presentation of the HIV sialadenitis is lymphoepithelial cysts in the salivary glands, primarily the parotids. It's a diffuse cystic enlargement of the major glands, mostly the parotids. This may happen early in the disease or may present at a later stage. It usually starts as a gradual, non-tender enlargement of one or more of the major salivary glands, mostly the parotid. Plus, they would also have reduced salivary secretions producing xerostomia. The two features, the salivary gland swelling and xerostomia, is quite similar to the clinical picture of early Sjögren syndrome, but of course the antibodies against Sjögren syndrome, anti-Rho and anti-LA antibodies, would be missing. Imaging of the salivary glands would show multiple low attenuation cysts, these lymphoepithelial cysts, with diffuse lymphadenopathy affecting the salivary glands and the head and neck glands as well. Treatment of salivary gland associated disease is not required unless there is a notable cosmetic deformity of the salivary glands involved or if there is xerostomia. The classic treatment with antiretroviral therapy had been shown to lessen the onset of the HIV salivary gland disease. It may also reduce the swelling. On the other hand, there is now some evidence to the contrary, in that the protease inhibitors of the ART may actually increase the swelling through fat deposition in the gland and may also lessen the salivary secretions. The swelling of the salivary glands can be treated by mild doses of local radiotherapy. External radiation with a very small dosage can cause a transient improvement in the swelling size. With a higher dosage, you can achieve almost complete resolution of the disease that may last for at least several years without causing excessive xerostomia. There are other lines of suggested therapies, including repeated aspiration of the lymphoepithelial cysts and even injection of tetracycline as a sclerosing agent in these cysts, and sometimes surgical removal of the enlarged gland if all other methods fail to control the swelling. And then we move now to bacterial sialadenitis. This can cause an acute suppurative process in the salivary glands that has an acute onset of painful swelling in the salivary glands, usually the parotid, but it can also affect the submandibulars. There will be also some purulent discharge coming out from the duct orifice into the oral cavity. The patients would notice the funny taste in their mouth. They may have cervical lymph nodes, pyrexia, and malaise. The two extremes of age, the geriatric population and the very young, are particularly prone for this type of inflammation. In the geriatric population, they may suffer from dehydration. In the very young, in the first 2 weeks of life, they may be on long-term orogastric tube feeding, which is a risk factor for acute sialadenitis. Pathogenesis is due to a combination of two factors: salivary stasis in the salivary glands and retrograde contamination of the gland by bacteria from the oral cavity. The salivary stasis would lead to bacterial overgrowth and inflammation. This can be caused by either dehydration, some medications, or salivary stones. The medications list include things like tricyclic antidepressants, antipsychotics, anticholinergics, beta blockers, and antihistamines. Salivary stones are responsible for about 50% of the cases of obstructive salivary gland disease. Cat scratch disease initially involves lymph nodes adjacent to the salivary glands and spread to the salivary glands directly. It affects patients exposed to cats, mostly children and young adults. The pathogen is a Bartonella hensleyi gram-negative bacteria. It can be detected in serology by a PCR reaction. Antibiotics, although generally prescribed, have little effect in the course of the disease. It does not shorten the course of the disease. The affected lymph nodes would usually disappear spontaneously within few months. Iodide mumps is a salivary gland reaction, particularly in the parotids, usually bilateral, in response to high levels of iodide compounds in the serum. It causes a mild acute response to things like iodine-based contrast media used in radiology, or iodine-containing compounds in expectorants, agents increasing serum iodide like thiouracil. It tends to be transient, develops within minutes, and causes painless bilateral parotid gland swellings, or sometimes the submandibulars can be involved. It gradually disappears over the next few days, usually within 6 days period. The salivary glands can preferentially concentrate the iodine in the serum, and this actually happens in the salivary glands ducts. This is a way of excreting iodines in the plasma. The cheap way of excreting the iodine would be the kidneys. Extremely high levels of plasma iodide can also cause a toxic effect on the salivary gland system. The duct wall of the salivary glands would be inflamed, and this would lead to obstruction of the ducts and glandular swelling. Iodide mumps can present in one of two forms, the most common of which is the immediate reaction form, which is probably allergic in nature and can be associated with things like urticaria and pruritus, or even bronchospasm and angioneurotic edema. The less common form is the delayed iodide reaction, which is usually due to a toxic reaction in the tubular cells of the salivary glands. And the preventive measures include, of course, not using the iodide-based contrast media in radiology if a patient has a history of a previous reaction. The low osmolar non-ionic dyes should be chosen instead. But if a reaction develops, anti-inflammatories, antihistamines, and steroids can be used. Some cases would resolve with no treatment if the reaction was mild. A third type of reaction to iodine is radiation sialadenitis caused by radioactive iodine used in the treatment of thyroid malignancy. The thyroid tissue and the salivary gland tissues can preferentially concentrate iodine from the serum. This would cause a transient, bilateral, but sometimes can be unilateral swelling of the salivary glands, again usually the parotid, but sometimes can affect the submandibulars, particularly to iodine 131. The effect is rapid in onset and is also dose related. It would cause tenderness in the parotid glands within 24 hours of the ingestion of the iodine 131, but can be expected to resolve within a week. The preventive measures used to reduce the radiation-induced sialadenitis would be based on trying to increase the salivary flow rate. The rapid flow rate would decrease the transient time of the radioactive iodine through the salivary gland ducts. So the use of things like chewing gums or sour candies can be of help during the immediate post-therapy period to increase the salivation. Also, salagogues like pilocarpine can be used before and after the treatment. The amofistine, which is used, this is a radioprotective agent that has been used in several head and neck tumors to protect against radiation-induced damage, has not been used extensively with thyroid cancer to protect the salivary glands. If the radiation-induced damage actually develops, endoscopy can be helpful. The damage of the tubular cells can cause mucus plugs and ductal debris, and endoscopy can help in unclogging these ducts and resuming normal salivary flow. And this is the long list of other drugs and medications that can cause salivary gland disturbed functions, including things like antithyroid agents, or iodized insulin, interferon, chlorhexidine, cimetidine, clonidine, ganglion blocking agents, and other types of medications. Pneumoparotid, or air in the parotid gland, develops when air is forced from the mouth through the parotid ducts into the parotid tissues. This is usually unilateral but can sometimes affect the parotid bilaterally. This is usually caused by an increase in the intraoral air pressure due to the use of musical wind instruments, glass blowing, or even forcibly blowing up the cheeks, either consciously or sometimes as a neurotic habit. The parotid duct orifice has a slit-like opening shape covered by a redundant fold of oral mucosa over the orifice. This usually discourages the air reflux into the parotid duct. When this happens, it gives a sense of fullness in the parotid, and the air can be felt on palpating the parotid like tissue emphysema. Sialography would show that the ducts are hugely dilated and would show some radiolucences within the duct due to the air pockets. Pneumoparotid usually spontaneously regress within hours and requires no specific treatment. If repeated several times and very often, it can cause chronic parotitis. The management of chronic parotitis due to this intractable form of recurrent pneumoparotid would sometimes include rerouting of the parotid duct into the tonsillar fossa. Very rarely there will be any indication for surgical removal of the gland, only when the intractable recurrent parotitis can cause a severe form of chronic inflammation. Anesthesia mumps refers to parotid gland swelling following general anesthesia. It's usually bilateral but can sometimes be unilateral. It's generally thought to be due to Pneumoparotid due to the increased intraoral air pressure induced by straining and coughing during intubation or during endoscopy, bronchoscopy, or rigid esophagoscopy. This is helped if a muscle relaxant agent is used during anesthesia, because this can lead to a decrease in the muscle tone around the Stensen's duct orifice. The other theory for the development of the anesthesia mumps is a pharyngeal reflex theory. This is caused by parasympathetic nerve stimulation that leads to vasodilatation and hyperemia of the parotid gland. This is initiated by tracheal intubation associated with coughing and straining. This can stimulate the pharyngeal reflex. It's usually transient in nature and will settle within a day or so and requires no specific treatment. Recurrent parotitis can either be caused by the more common juvenile recurrent parotitis or the other form of the disease which affects the adults. This is an inflammatory disorder of the salivary gland, affecting almost always, but not exclusively, the parotid glands. It's of a non-obstructive nature. The ducts are actually widened rather than narrowed or blocked. It affects children up to the age of 16. There is a somewhat different version of the disease that affects adults. It's usually unilateral, affecting one parotid at a time, but occasionally, in less than a fourth of the cases, it may affect the two glands. And it is recurrent. Then children will have 2 or more episodes before puberty, sometimes up to 10 episodes in a year or more. The onset of the inflammatory episode is usually sudden, with a rapid increase in the size of the affected parotid gland, usually on one side. There will be an overlying erythema of the skin and pain in the parotid gland, and there would also be fever. If the gland is gently pressed or massaged, a whitish discharge could be expressed from the parotid papilla. The parotid papilla itself would always be hyperemic. The acute episode would last anything between 3 and 7 days, but this can extend up to 3 weeks in some severe forms. Often, the first episode of the parotitis is attributed to mumps before the true nature of the disease is diagnosed. In areas where there is widespread vaccination against measles, mumps, and rubella, the MMR vaccine, the incidence of mumps is now next to 0. It's highly unlikely that the children will be affected by mumps after 2 doses of the triple vaccine. How the disease develop? The most significant element in the development of the disease is this: the dilatation of the parotid duct. This sialadenosis, perhaps combined with decreased salivary production as well, would favor ascending infection of the parotid gland through the oral cavity. This would cause partial obstruction of the ducts with mucus plugs sometimes, or debris or inflammatory exudate, and this would result in further dilatation due to the kinking or the partial obstruction of the duct. Also, there will be some distortion of the duct itself, as you could see, and with an inflamed areas and fibrous healing of these inflamed areas, some strictures could also be noted. Despite the generalized dilatation, there will be localized strictures in many areas, giving the duct this beaded-like appearance. Then metaplasia of the covering epithelium would cause excess mucus production and mucus plugs, and this would cause further reduction in salivary flow rate and predispose to recurrent infections. This hypoechoic areas would give the appearance of a Swiss cheese or a moth-eaten enlarged heterogeneous gland. The areas of the lymphocytic infiltration would give a hyperemic echo on the Doppler and are usually surrounding the sialadenitic areas, the hypoechoic areas. Parotid sialography entails the installation of a radio-opaque material into the duct system, usually iodine-based. This would give a very clear image about the duct system, including its caliber and its arborization up to its very peripheral ducts. The features in juvenile recurrent parotitis are basically a dilatation of the distal duct that extends either to the two-thirds or the whole of the gland, depending on the severity of the condition. This dilatation can also be associated paradoxically with some narrowing, some narrow segments of stenosis that are usually due to the inflammatory process and the healing with scar tissue. There may be also kinking of the duct system and distortion of the distal duct. These are the characteristic features of the parotid sialogram in juvenile recurrent parotitis, and this imaging modality can also help in classifying the condition to mild, moderate or severe according to the extent of the disease into the 1/3, 2/3 or whole of the parotid gland. Parotid sialoendoscopy is useful not only in confirming the diagnosis but mainly for the management of the condition. It shows some features of the disease, including the dilatation of some segments of the distal ducts and localized stenosis due to fibrosis in some parts, multiple stenosis in some parts of the dilated ducts. You can see mucus plugs inside the ducts and scar tissue in the mucosa, but the characteristic appearance would be this whitish lining of the inside of the duct due to the squamous metaplasia of the repeatedly inflamed duct surface, and you can no longer see through the thin epithelium the blood vessels underlying the duct lining. This whitish appearance of the duct is considered by some a characteristic feature of the disease. It's useful in confirming the diagnosis, but similar features can also be seen in other autoimmune conditions, including Sjögren's disease. And now to the management of juvenile recurrent parotitis, and these include a long list of suggested therapies, including symptomatic treatment with painkillers and antibiotics, analgesics, intraductal injection of saline with or without dilatation of the duct, or installing antibiotics or antiseptic solutions, or steroids. Also sialography with high concentration of iodine, or sialoendoscopy with duct dilatation with balloons in the multiple stenotic segments. Other forms of treatment used in the past, like ligation of the duct or injecting a sclerosing agent in it, radiation of the parotid, or even parotoidectomy or tympanic neurectomy have fallen out of favor. Most of these other forms of treatment are no longer used. Adult version of recurrent parotitis, RPA, is usually bilateral, but at times can be unilateral. It can arise de novo in adult life or can be a progression from juvenile recurrent parotitis. The inflammatory process would cause progressive gland parenchymal degeneration, sometimes associated with acute episodes, during which pus can be seen coming out from the Stensen's duct orifice. The histopathological features are duct dilatation, sometimes with some metaplasia of the duct cells, and acinar cell atrophy and interstitial parenchymal fibrosis. The fibrosis is mostly periductal due to the inflammatory infiltrate, which is predominantly lymphocytes, sometimes plasma cells and eosinophils as well. Sialography can be useful in establishing the diagnosis of recurrent parotitis in adults. It shows this characteristic sausaging. This is due to the sialactasis, the significant dilatation of the duct system, associated with occasional fibrosis at certain segments due to scar tissue formation or the weakening of the duct wall. CT scans of patients with recurrent parotitis in adults would usually show bilateral parotid gland increased density due to the inflammatory infiltration that displaces the radiolucent fat content of the parotid. The management includes treating the acute infection episodes, and for the chronic recurrent form, patients who have mild complaints may be helped with sialogogues and parotid gland massage. Sialogogues would increase the flow of saliva in the duct system and reduce the accumulation of the debris and mucus plugs. The same effect could be obtained by massaging the glands to flush out any obstruction to the duct system. Steroids and antibiotics can also be used, particularly during the acute episodes, and sialoendoscopy, if available, would be helpful in unclogging any duct obstruction, sucking out mucus plugs and removing any debris. In the very severe forms or the intractable forms, the treatment options would include trying to induce fibrosis of the duct system by intraductal injection of agents like methyl violet, which would cause an inflammatory response followed by fibrosis and glandular atrophy, or even ligation of the main duct to induce glandular atrophy as well. Occasionally, subtotal or even total gland excision may be required in very severe forms. We now move to the chronic form of parotomegaly caused by conditions such as sialadenosis, Sjögren syndrome, Granulomatosis sialadenitis, chronic sclerosing sialadenitis, the IgG4-related disease, the Warthin's tumors, the MALT lymphomas, the Polycystic parotid disease, and the Granulomatosis with Polyangiitis, the former Wegener's Granulomatosis. The disturbance in the saliva secretion process would lead to swelling of some of the major salivary glands, usually pairs of them, almost always the parotid, but occasionally also the submandibular. It's not an inflammation and it's not a tumor. It causes a swelling of the glands that is usually persistent but occasionally recurrent. Most frequently, the patients would have another underlying systemic condition like diabetes, or he may be an alcoholic, or malnutrition, or either anorexia or bulimia nervosa. The association between malnutrition and the swelling of the parotid glands was noted almost 200 years ago in Egypt, but also in other parts in the world like South and West Africa and in the prisoners of war. The condition is often painless, but not invariably so. The precise etiology is probably multifactorial, but the underlying pathogenesis is autonomic nervous system neuropathy. This results in a disorder in the autonomic nervous system control of the saliva secretion. This may be either an inhibition of the parasympathetic activity or an increase in the activity of the sympathetic drive. This would lead ultimately to a swelling of the major salivary glands by increased contents of zymogen granules in the acinar cells of the glands. This may be either due to an increase in the formation of the zymogen granules or an arrest or a decrease of its release by exocytosis into the ducts to form the saliva. So, how the sialadenosis develop? Histological and ultrastructural investigations points to two sets of abnormalities in the salivary tissue in glands affected by sialadenosis. The first relates to the acinar cells, the size of the acinal cells and its structure, which is formed mainly of zymogen granules, and its innervation. This is the number 1 disorder. The number 2 is the myoepithelial cells surrounding the acinar cells, which also show some degenerative changes. They are under the parasympathetic control, and they help in the release of saliva into the tubular system, and abnormalities in the myoepithelial cells could also possibly explain the development of sialadenosis. In the early stages, the histopathological changes would include acinar cell hypertrophy, myoepithelial cells atrophy, and pressure changes on the ductal system, with no inflammatory signs. With time, gradually the fat in the parotid or the other salivary glands would be replaced by the swollen and the hypertrophied acinar cells. This will give the gland a hyperdense signal on CT scans, for example, as progressively the fat will be replaced by the salivary tissue. But with time, the chronic stage, the end stage, there will be an atrophy of the salivary tissue, and the gland would be basically formed of fat content progressively, sometimes due to fat infiltration rather than just fat replacement. So the cellular hypertrophy and the fat infiltration are actually different stages of the same process. In the early stages, it is the cellular hypertrophy of the acinar cells, and in the late stages, it is the fatty infiltration of the gland. Here is a comparison between the normal parotid gland and a gland with sialadenosis using the same magnification power in the 2 slides. This would be the average size of the acinar cluster compared with the acinar cluster in the sialadenosis group. The average diameter of the acinar cell in normal individuals would be up to 40 micrometers. This could could be doubled or even tripled up to 100 micrometers in patients with sialadenosis. There will also be signs of derangement of the autonomic nerve system terminals and degeneration of the myoepithelial cells and lack of any signs of inflammatory cells. CT scans would be rarely indicated in patients with sialadenosis. In cases of parotid sialadenosis, they would show diffuse enlargement and symmetrical enlargement of both glands. In the early stages, the enlargement would be hyperdense because it's basically formed of hypertrophied acinar cells. In later stages of the disease, this would be replaced by fat, and the density of the gland would be shown as hypodense, again bilateral enlargement, but with a hypodense compared to the hyperdense appearance in the early stages. There will be no signs of any focal lesion. In bulimia nervosa patient, the stopping of the vomiting is generally associated with resolution of the sialadenosis, but this may take few weeks or few months. And there are some reports that pilocarpine, which is a cholinergic agonist, can be used successfully to resolve the gland enlargement in sialadenosis, but the results are not very consistent. In 2 cases, it was used in bulimia nervosa, 2 case reports, and this showed that the use of pilocarpine drops orally can be helpful. Although there is some experimental evidence that catecholamines such as isoprenaline can produce sialadenosis, and sialadenosis is known to develop in patients who are using isoprenaline in the treatment of asthma, the use of beta receptor blockers has not actually resulted in much improvement. So this is not very useful. Also, the use of sialagogues that promotes the secretion of saliva, things like spices or lemon or acidic things, there are frequent reports that this has actually failed to treat the sialadenosis. Sjögren syndrome is one of the major causes of xerostomia. This is a chronic autoimmune inflammatory disorder characterized by lymphocytic infiltration of the exocrine glands in multiple sites, primarily the lacrimal and the salivary glands. It can occur alone and then termed primary Sjögren syndrome, or in conjunction with another autoimmune rheumatic disorder when it is a secondary Sjögren syndrome. Their prevalence is somewhere around 0.6% of the general population. Highest prevalence in the 4th and the 5th decade of life. It's 90% of the patients are females. The focal lymphocytic infiltration of the exocrine glands may lead to germinal center formation, consisting of around 80% T cells and 20% beta cells. This will produce antibodies and cause focal sialadenitis or inflammation of the lacrimal gland. Cytokines may also play an important role in the pathology. The clinical picture would be that of a dry eye, the keratoconjunctivitis sicca, and a dry mouth. There would be extraglandular manifestation as well, including transient or chronic bilateral enlargement of the parotid or the submandibular glands, seen in between 20 and 30% of the patients. There may be some oral complications, including dental caries, candida infection, difficulties with eating, swallowing, and speaking, and a general sense of fatigue and arthralgia. In the primary Sjögren syndrome particularly, there is a high risk of developing a non-Hodgkin's lymphoma. The risk is more than 18 times that of the general population. There is also a high risk of developing autoimmune thyroiditis. 1 in 8 patients will develop autoimmune thyroiditis, or autoimmune hepatitis, interstitial lung disease, and interstitial nephritis. Interestingly, the minor salivary glands of the palate may not show the full manifestations of Sjögren's disease, the lymphocytic infiltration of the salivary glands. The diagnosis of Sjögren's disease could be established by objective measurements of saliva outflow and objective measurements of tear secretions. Salivary gland biopsy, usually taken from the lower lips, minor salivary gland biopsies, would also confirm the diagnosis and help in the scoring of the chronic inflammatory process. Estimation of the autoantibodies in the serum, serum autoimmune antibodies in patients who have Sjögren's syndrome could have the antigen, the SS-associated antigen A or B, and recently the ultrasound high frequency intraoral imaging is used in the grading and confirmation of the diagnosis of Sjögren syndrome. And these are examples of ultrasonography for normal patients in this column, and for Sjögren syndrome patients in the other two. The upper row contains ultrasonography of the parotid, and the lower for ultrasonography of the submandibular. In the normal patients, you could see a homogeneous echo and no abnormalities in the gland contour itself, either the parotid or the submandibular. In the patients who have Sjögren syndrome, you could either see localized hypoechoic part, localized in the parotid and more generalized in the submandibular. This is grade 1 and this is grade 2, and the ultrasound score would therefore be 1 + 2 = 3. Or in a more advanced case, you could see hypoechoic bands, like bands of hypoechoic across the parotid or the submandibular. This is grade 4 in the parotid and grade 4 in the submandibular, and the total ultrasound score would therefore be 8. A parotid cyelogram will be obtained by injecting a radiopaque contrast medium through the parotid duct, and this would show the complete duct system of the parotid, including the arborization into the intraglandular small ducts and acinar spaces. And you could see in Sjögren syndrome the typical picture of a budding tree. A tree in bud. It shows as if this is a tree with early budding, multiple tiny area collections of the contrast in several areas around the arborizing duct system. Moving now to the management, and starting with 2 parasympathomimetic medications, both approved by the FDA for the use in Sjögren's syndrome. Pilocarpine was the oldest. This is a non-selective muscarinic agonist, works on MA3 muscarinic receptors and stimulates the residual functioning salivary tissue. and at least 2 randomized controlled trials had showed its efficacy and confirmed significant increase in saliva output, as well as improved subjective measures, including a sense of moisture in the oral cavity. It works for a few hours, somewhere around 2 or 3 hours. That's why it is taken in 3 times a day, starting with a dose of 5 milligrams orally and titrating the dose up if required, up to 10 milligrams 3 times a day. It has the highest possible recommendation grade. Level of evidence is A. It would take some time before its full efficacy is shown, somewhere around 2 months after starting the medication, before the maximal effect is reached. The other parasympathomimetic is 7-methylene hydrochloride, which is a derivative of acetylcholine. It is an acetylcholine analog. It works selectively on M3 receptors, muscarinic M3 receptors in the lacrimal and salivary glands, and other exocrine glands such as the sweat glands, the pancreas, and the intestinal glands. But it can also increase the muscle tone and motility in the GI and the urinary tracts, but have very little effect on the cardiac and the pulmonary receptors. It has been approved by the FDA for the relief of the xerostomia in patients with Sjögren's syndrome. And in at least 2 randomized controlled trials, 7-methylene hydrochloride was tried on primary and secondary Sjögren's syndrome patients, and in both randomized controlled trials, the oral 7-methylene improved the xerostomia, subjective sensation, and the hyposalivation objectively. It's recommended to give 7-methylene at 30 milligrams 3 times a day orally for both the primary and the secondary Sjögren's syndrome patients, and this recommendation has taken the highest class 1 recommendation. Level of evidence is A. And saliva substitutes or artificial saliva. Using oral mouthwashes, gels or rinses or sprays, and or artificial saliva can all help to reduce the discomfort and improve the function of the oral cavity momentarily. These oral care products are specifically formulated for the dry mouth. They contain no detergents, they have a mild taste, they contain antimicrobial routine. They also contain a thickening agent to provide some viscosity, plus their protective properties. So they have different composition and different viscosity. Among these agents is of prime importance the carboxymethylcellulose, a mucopolysaccharide, but other agents can also be used, including glycerate polymer, gel base, or natural mucines, hydroxyethylcellulose, xanthan gum, glycerol, linseed, polyethylene oxide, plus the addition of some salts, preservatives, and sweeteners. The chronic sclerosing sialadenitis is a chronic fibroinflammatory condition that can affect salivary glands among other organs in the body. The condition is benign but presents as hard and indurated and enlarged mass. So it can often be diagnosed as a malignant lesion. And clinically, it's very similar to the presentation of malignant neoplasm in the salivary glands. The condition is now included in the immune-mediated IgG4-related disease. This IgG-related disease may be easily confused with the following: malignancy in the salivary glands or the lymph nodes, Sjögren's syndrome, vasculitis, or an infection in the submandibular gland, or even submandibular stones. The IgG4-related disease is basically an immune-mediated, multi-organ, fibroinflammatory disorder that can involve many organs in the body, including the salivary glands, the major salivary glands, particularly the submandibular glands. When infiltration of the glands happens, it forms masses that can mimic a pseudo-tumor. In the head and neck region, this is one of the most common sites of the IgG4 related disease, affecting about 1/5 of the patient with the condition. It comes second only to the pancreas and the sites affected by IgG4-related conditions. This condition is characterized by the formation of the infiltration, composed mainly of plasma cells that are tagged with IgG4 cells and other lymphocytes, including T cells, and extensive fibrosis affecting these organs. This infiltration can then lead to organ dysfunction, whether it is in the salivary glands, lungs, pancreas, or other organs. Mikulicz disease present as symmetrical enlargement of lacrimal glands, parotid glands, submandibular salivary glands, and even sometimes the sublingual salivary glands as well. And occasionally it presents with xerostomia or ocular dryness. On the other hand, Kuttner's tumor specifically affects the submandibular salivary gland. It has less severe manifestation of the IgG4-related disease, predominant fibrosis, enlargement, and sclerosis of the submandibular gland particularly. It's considered as a subtype of the Mikulicz disease that affects more widely other salivary glands and the lacrimal glands as well. And in Kuttner's tumor, the condition can cause calcification in the ducts and mucus plugs in somewhere between 30% and 80% of the patients. This is basically secondary to the inflammatory process and the diminished secretion of saliva in the affected glands. This can produce stones and can produce recurrent inflammation in the submandibular gland that can easily mimic recurrent submandibular inflammation due to stones. The pathological features of the IgG4-related disease include dense lymphoplasmocytic infiltration and obliterative phlebitis. The venous drainage can be partially or completely blocked by this lymphoplasmocytic infiltration. This is one of the characteristic features. The other is this, what is called storiform fibrosis, a pattern of fibrosis like a woven fabric. This is also a characteristic feature. In addition, you could see reactive lymphoid follicles within the infiltration, marked by lack of atypical lymphoid cells. This is important to differentiate this from lymphomas. There is also some atrophy and loss of the acini and the salivary glands, and the glandular tissues, the acini and the ducts, can be enveloped in thick fibrosis. Unlike Sjögren syndrome, there is an absence of the lymphoepithelial lesions, and there is semi-preservation of the gland architecture. The normal lobular pattern of the gland is preserved because the inflammatory process may be localized to only one part of the gland, or sometimes throughout the gland, but in others it can be only affecting one side, preserving the normal architecture. Blood tests can be useful. There may be hypergammaglobulinemia. There may be an elevated serum level of IgG4 exceeding 135 milligrams per dl. This is seen in just about 2/3 of the patients, particularly those who have multi-organ involvement. In just less than 1/3 of the patients, the IgG4 serum level would not be more than the normal. IgG4 serum level is not exclusively observed in the IgG4 related disease. It can be seen also in other conditions, so it's not specific. But if you find high serum levels of IgG4 in the absence of histological features, including immunohistochemistry, then the establishing the diagnosis should be done with some caution. The absence of circulating antibodies against Sjögren syndrome is also useful in distinguishing the two conditions, but it is the histopathological confirmation that would establish the diagnosis, particularly with staining. And these are the general features of ultrasonography of the IgG4-related disease, basically bilateral, heterogeneous, glands with multiple areas of hypoechoic regions and hyperemic areas in the glandular parenchyma, and also duct dilatation, particularly in the submandibular gland. MRI scans are more useful because they usually show a low signal intensity on the T1 weighted images and also on the T2 weighted images. The density would be low to intermediate, although sometimes it can be hyper intense like in here. There will be also enhancement of the lesion, and there will be a restricted diffusion. So it would generally show bilateral enlargement, with areas affecting the lesion would be usually hypo-intense on T2, but sometimes hyper or even iso-intense, and the enhancement feature is also characteristic. And now to the management. When the disease is asymptomatic, no therapy may be considered, because up to 30% of the patients may undergo spontaneous remissions. If therapy is indicated, short-term steroids may be the best initial treatment. It can even cause an increase in saliva production in the affected patients, in sharp contrast to Sjögren syndrome cases. The rapid response to the steroids is almost diagnostic. If the patient does not respond to prednisone at a minimum level of 40 milligrams daily for up to 4 weeks, then you may start to think whether the diagnosis is correct or not, because usually there will be significant improvement in the gland size and function during this short window of time, although some cases may be refractory to the treatment with steroids and will need immunosuppression. Sarcoidosis, which is a chronic multisystem granulomatous disease with a predilection for the lungs and the mediastinal hilar lymph nodes, usually presents with respiratory symptoms like coughing, dyspnea, or chest pain. But it can also involve the major salivary glands, particularly the parotid, involving both sides, and at times the submandibular glands. It affects the parotid in somewhere in between 4 and 30% of the patients with sarcoidosis, and can cause xerostomia and a firm, slightly tender and painful salivary gland swellings. Laboratory tests in the acute phase would show a reduced level of amylase and kallikrein, and an elevated level of calcium and alkaline phosphatase, together with hypergammaglobulinemia. But it is the increased serum level of angiotensin converting enzyme, the ACE test, is what draws attention to the possibility of sarcoidosis. VIME test, which is an intradermal injection of sarcoid material under the skin, is positive in about 80% of the patients. The imaging would include radiolabeled gallium scans, which would show the characteristic lambda sign of mediastinal hilar lymph nodes involvement, and the panda sign of involvement of the lacrimal and the salivary glands. This is not entirely diagnostic, but is very suggestive of sarcoidosis. A labial salivary gland biopsy would show the granuloma in just less than 2/3 of the patients. The sensitivity is less than taking biopsies from the parotid, but is of course much safer. It would usually show a non-caseating granuloma. The core is formed of epithelioid cells and giant cells, and the periphery of lymphocytes and fibroblasts. The treatment is usually steroids. A special form of sarcoidosis is the Hereford's syndrome, which is not very common and involves a complex of symptoms, including the eyes, uvea tract, the bilateral parotid gland swelling, and occasionally cranial nerves, usually the 7th cranial nerve, as transient paralysis. It affects usually young patients in their 20s, and the treatment is generally symptomatic because spontaneous resolution can be expected. Steroids would be indicated in the severe form of the disease, particularly if the disease is aggressive in their eye symptoms, to abort advancement of the condition to ocular lesions and blindness. Mycobacteria tuberculosis and its atypical form can both affect lymph nodes, either adjacent to the major salivary glands, particularly the parotid, or sometimes the intraglandular lymph nodes. The infection is usually mixed, being contaminated by the local flora of the mouth and the pharynx, which can therefore present either by an acute inflammatory process or the more usual chronic swelling of the lymph nodes. The diagnosis is initially by the PPD skin test, followed by the fine needle aspiration. And the treatment, depending on the local protocols, is usually medical with a combination of antibiotics, including isoniazid, rifampicin, and pyrazinamide. The atypical mycobacteria infection caused by the Mycobacterium avian, the avian version of the Mycobacterium, would usually affect young children between the age of 2 and 5 years, but can also affect adults who suffer from immunodeficiency. The diagnosis can be delayed because the classic PPD test is usually negative, but a specific PPD test from the Mycobacteria avian would show positive results. Or a culture can be made from the resected lymph nodes or the open wounds, and this will again show the offending organism. The treatment is usually surgical excision. Sometimes curettage of open wound can also be helpful, and sometimes chemotherapy with several antibiotics can also be required. And now to tumors causing bilateral parotid swellings, starting with papillary, cystadenoma, lymphomatosum, the formerly called Warthin's tumor. This is a benign epithelial tumor from salivary gland tissue. 10% of the cases can cause multifocal lesions within a single parotid gland. Again, around 10% of the reported cases are bilateral, and it forms about 10% of all parotid tumors, being the second most common benign parotid gland tumor after pleomorphic adenoma. It has a special predilection to the lower pole of the superficial lobe of the parotid gland, but it can affect other sites, including the submandibular or even the sublingual salivary gland. Males are affected more, up to even 10 to 1, and it affects usually individuals above the age of 40 years. The mean age of the affected persons will be about more than 60 years old, and there is a strong association with smoking. The presentation is of a well-defined, slowly growing, firm to soft mass in the parotid gland, particularly the lower pole. Usually single, but in 10% of the cases it can be multifocal within a single parotid gland. It's painless and it's mobile and usually completely encapsulated. It can get infected, can pick up infection and becomes very painful and tender. Microscopically, it's composed of epithelial and lymphocytes elements. Epithelial elements which cause papillary, frangous, glandular, and cystic formation, and the lymphocytes can cause multiple germinal centers. The cysts would contain secretions formed of amorphous material with cholesterol clefts containing the epithelial cells and the inflammatory cells. Imaging by CT scan or MRI would show a well-circumscribed lesion with mixed areas of translucency due to the cystic elements or solid elements which would be opaque. The treatment is usually superficial parotoidectomy, sometimes a hemi-superficial parotoidectomy, removing only the lower half of the superficial lobe would be enough. Recurrent rates are fairly high, between 9 and 15%, possibly due to the multifocal nature of the lesion. Malignant transformation to either squamous cell carcinoma or mucoepidermoid carcinoma or even a lymphoma has been reported but is fairly rare. Xanthogranulomatosis sialadenitis is a very rare condition, sometimes reported in association with Warthin's tumor, particularly after a fine needle biopsy or a fine needle aspiration. It manifests as a solitary, painless, but hard mass in the major salivary gland. Histologically, it is characterized by lipid-laden macrophages, the Lymphoma cells. These are foamy macrophages full of fat. It's surrounded by chronic and acute inflammatory cells, and it is non-caseating granuloma. It is reported after fine needle aspiration biopsy of the affected salivary gland, but there are few supporting data to conclude that it is the only cause of such a granulomatous inflammation. The treatment is excision, particularly if it is associated with a Warthin's tumor. Malignant lymphoma of the parotid and the salivary glands are usually derived from the mucosa-associated lymphoid tissue, the MALT. It's called the MALT lymphoma. We know that Sjögren syndrome increases the risk of developing this type of lymphoma more than 44 times. 80% of salivary gland lymphomas occurs in the parotid, and almost all of them occurs in females. It predominantly affects the elderly above the age of 60 or so, and it's usually a low-grade beta cell lymphoma of marginal zone type. When parotid glands are affected by Sjögren syndrome, there is a periductal lymphocytic infiltration. These lymphocytes are polyclonic, more than just one clone, predominantly T cells over the beta cells, and are reactive. With continued infiltration of the lymphoid tissue, the normal parenchyma of the salivary tissue would be replaced. Some ductal epithelium cells would proliferate and form islands of lymphoepithelial islands like this. The salivary gland pattern of infiltration and duct proliferation is now referred to as lymphoepithelial sialadenitis, LYSA. Now, 4 to 7% of patients who have LYSA will develop a lymphoma. This would be usually a beta cell in type and would be monoclonal beta cell lymphoma of the MALT type. Most salivary gland lymphomas are extranodal and histologically are marginal zone beta cell lymphomas. However, there are other less common types, including follicular lymphoma that may arise from an intrasalivary salivary gland lymph node, or the diffuse large beta cell lymphoma. This is a third type of lymphomas that may arise de novo or can follow the MALT type of lymphoma or even the follicular lymphomas. Salivary lymphomas can involve any salivary gland tissue, but bilateral parotid enlargement are often seen. The most frequently observed type, the MALT lymphoma, occurs in patients who had previously either Sjögren syndrome or HIV disease, because the risk would increase several tens of folds. A tumor has long history, is very slow in nature, remains localized for a long period, and can eventually spread to regional lymph nodes, but not readily to other distant sites. Lymphomas collectively form about 2 to 5% of all salivary gland tumors, mostly MALT lymphomas. They vary in size, but can be very large and can have persistent, firm, but painless swellings in both parotids. With or without treatment, the behavior pattern of most MALT lymphomas result in little morbidity or mortality. That's why if there is no systemic involvement, sometimes conservative treatment can be adopted. In the very localized type of the disease, the treatment options include surgery and or radiation, whereas in the disseminated disease, chemotherapy may be required. In other types of lymphomas, including the high-grade beta cell lymphomas, if the tumor has transformed to it, or in follicular lymphomas, then more aggressive therapeutic management with chemotherapy and radiotherapy may be needed. Granulomatosis with polyangiitis, previously known as Wegener's granulomatosis, has a histological triad of granulomatous inflammation with vasculitis affecting middle and small vessels, arteries and vein, and necrosis. It affects mainly the respiratory system, upper and lower respiratory tracts, and the kidneys, and can present with bilateral parotid gland swellings, has no sex predilection, and affects mostly the 4th or 5th decades of life. The initial presentation usually involves respiratory symptoms and paranasal sinus symptoms. 90% of the patients would present with head and neck symptoms, including orofacial manifestations, with ulcerative stomatitis or hyperplastic gingivitis. In addition to the usual respiratory difficulties and sinus problems, patients may present with hearing loss, ocular pain, or other symptoms from the head and neck. Parotid gland involvement is usually bilateral but can be unilateral and can be associated with pain and fever. The untreated cases would eventually die from kidney failure. Investigations include the immunofluorescence detection of the antineutrophil cytoplasm antibodies ANCA. This will be detected in almost all patients who have active generalized disease, but has much lower sensitivity if the disease is of a limited form, which is the case in patients who present with salivary gland symptoms. The positive ANCA here would be about 2/3 of the patients only. That's why it's important to repeat the ANCA test even if it is negative, if there is clinical suspicion of the granulomatosis with polyangiitis. The diagnosis is confirmed by biopsy that would show the classic triad of the disease. The treatment protocols would be based on prednisone and cyclophosphamide. Regression of the inflammatory process and the swelling would be expected in the parotid glands. Clinical relapse may happen during tapering down of the medications, but resuming the dosages of these medications would lead to remission. And finally, the polycystic parotid disease, which is a rare congenital lesion of the parotid glands that may have a hereditary background. It presents with a non-tender, slowly progressive, and almost always bilateral parotid gland swellings, affect females more in their childhood or early adult life. Histologically, they form several various sized cysts lined by thin cuboidal or squamous epithelium. The cysts are filled up with clear fluid with areas of dystrophic calcification. In between the cysts, the parotid parenchyma remains normal with little inflammatory infiltration. Imaging by CT scan or MRI scans or even ultrasound would show the presence of the multiple various sized cysts. They can also be seen on sialography. The ducts on sialography are stretched around the cysts but remain of normal caliber. Some of the cases had resolved spontaneously. That's why just observation can be a line of treatment, particularly if the patient is asymptomatic. If there are symptoms because of the bilateral swelling, then surgical intervention may be required, usually in the form of superficial lobectomy, but this can be followed by a recurrence from the deep lobe that is surgically retained, and total parotidectomy is the definitive treatment. By this, we come to the end of this presentation on bilateral parotid gland swellings. Assalamu alaikum.